Welcome to the Psychexperience.
Hello everyone and welcome to the Psychexperience. I am Dr. Nardi. I have Pedro here with me and today we're going to interview Dr. Joanna Moncrieff. Dr. Moncrieff has extensive experience with psychiatric rehabilitation in inpatient units, helping people with severe and long-lasting mental health problems. She remains active in clinical settings. She researched the overlap of sexual trauma in patients attending alcohol treatment services. And she teaches and does research at University College London. Dr. Moncrieff is one of the founding members and the co-chairperson of the Critical Psychiatric Network that consists of a group of psychiatrists from around the world who are fairly skeptical of the idea that mental disorders are simply brain diseases and of the dominance of the pharmaceutical industry in that paradigm. She has many insightful papers on the excesses of psychiatry and psychiatric medications, as well as on efforts to expand diagnosis in order to justify use of medications. My favorite one being her paper on bipolar disorder. She's the author of Psychiatric Drugs, The Truth About How They Work and How to Come Off Them, which is a reading I've been recommending to all my colleagues since I got in touch with it. It's available on Amazon. More recently, and all over the news, Dr. Moncrieff published a systematic review of available studies to debunk the idea that depression is a disease of the brain once and for all. Dr. Moncrieff, Joanna, thank you for joining us today.
Thank you. Nice to be here.
I'd like to start then by asking you to explain to us the drug action-centered model as an alternative to the disease-centered model that you explain in your book.
Okay, yes. So let's dive straight in. So this is what I've been working on for most of my professional life. And what I've been saying is that we have this traditional idea that psychiatric drugs work by targeting an underlying biological abnormality and helping to reverse it or rectify it in some ways. So that's like sometimes we talk about that abnormality being an underlying chemical imbalance, like a serotonin deficiency. And we think that the drugs work by helping to replenish serotonin levels. And that's what I've called the disease-centered model of drug action. It focuses on the idea that the drugs are targeting an underlying abnormal or disease process that gives rise to symptoms. And I've suggested that psychiatric drugs don't work like that, partly because we have no evidence that there are these underlying abnormalities that drugs might be targeting in that way. And I've suggested that instead, what we should think of psychiatric drugs as doing is as inducing altered mental states. Now, psychiatric drugs are drugs that cross the blood-brain barrier and they change the normal state of the brain. They change our normal brain chemistry. And by doing that, they produce changes to our feelings, thought patterns, emotions, behaviors, reaction times, sensations, sensitivity to the world, etc. And those alterations that they produce can be superimposed onto someone's underlying problems if they are experiencing problems of depression or anxiety. The drug-induced alterations are superimposed onto them and can temporarily override those underlying problems. So an example I could give is it's a bit like using alcohol. If you have a lot to drink, it often overrides your underlying feelings of anxiety or depression while you're under the influence of alcohol. Now, psychiatric drugs don't cause euphoria in the same way that alcohol or some psychiatric drugs do, actually, like benzodiazepines, but there are other classes of drugs, like most antidepressants and antipsychotics, that don't cause euphoria. They're not very pleasant to take. People don't crave them or go out seeking them. But nevertheless, they are inducing an altered mental state, producing an altered mental state, which can be superimposed onto underlying difficulties. And there may be occasions where superimposing a drug-induced state is preferable to someone experiencing their underlying difficulties. So an example might be if someone is very agitated and distressed and suicidal, it might be better for them to take a benzodiazepine and be relaxed and be able to sleep well for a few days. When someone's acutely psychotic, one of the alterations that is produced by antipsychotics is this emotional dampening and cognitive sort of slowing, and it might be better to be in that slightly dampened, slowed state than to be completely preoccupied with psychotic symptoms and experiences. So those are my models of drug action. So just to summarize quickly, what I'm saying is that we have no evidence that drugs work by targeting underlying abnormalities. We actually have lots of reason and justification to think that they work by inducing altered mental states, which may, in certain circumstances, be useful by replacing underlying feelings and symptoms. If you take a drug-centered view, if you accept that these drugs are drugs that are acting on brain chemistry and changing our normal brain chemistry and changing our normal mental states, you then have to ask questions. You then have to worry about what their long-term effects might be. And so I think taking this drug-centered view leads to, or naturally encourages people to be more cautious about the use of drugs.
Perfect, absolutely. I was going to make an analogy like, so let's assume I hurt my leg and I'm feeling pain. My body is working perfectly because that's what I'm designed to do. But then I want to induce a malfunction with, say, ibuprofen or any painkiller, and that malfunction is at least temporarily desirable. And that's a very thoughtful way of thinking it, because yes, I would have concerns with chronic use of any other medication that is not treating an underlying condition. That makes a lot of sense. Now, using that lens.
Sorry, so can I just come back on that? Because
please.
Sorry, can I just respond to that example? So I think in some ways that's a good example, but it also, I think, highlights a difference between using pain medication or physical medications and using psychiatric medications, because painkillers do at least target the neurological processes that produce pain. But we don't know that psychiatric drugs are targeting anything. And yet they are producing these altered mental states that they may be working through. The analogy, I would say, is between their use, the use of psychiatric drugs, and the use of opiate painkillers. So opiate painkillers, unlike your paracetamol or your, aspirin, have mind-altering effects. And part of the effect of an opiate painkiller is the mind, is their alteration to normal emotional or normal feelings. So people who take opiates for pain may say that they still have some pain, but they don't care about it anymore. And that's a consequence of the fact that opiates induce this altered mental state that is characterized partly by feelings of emotional detachment and indifference. And that aspect of their action is similar to what I'm suggesting is taking place when we give people drugs for mental health problems.
Perfect. And taking that lens, that approach, what kind of impact would SSRIs, SNRIs, or what we usually call antidepressants have in those conditions? Depression, anxiety, etc.
Yeah. So there's quite a bit of evidence that antidepressants produce an altered mental state, which is characterized partly by emotional blunting or numbing. So people who've taken antidepressants report quite consistently, actually, that they experience much less intense emotions, both so their negative emotions like anxiety and depression are muted, but so are their positive emotions like happiness and joy. And so I think that this is going to be happening to people who take antidepressants. Some people might find that effect to be welcome if they're feeling very intensely unhappy or anxious, but but you can see that there are likely to be some harmful consequences to being in an emotionally muted state. You may, for example, put up with a bad situation for longer than you should do. You might not make that decision that you need to make to leave your job that is causing you a lot of aggravation, or to leave a relationship where you might be being abused or mistreated. So I think emotional numbing, may have those negative consequences. Plus, actually, a lot of people just really don't like it because they lose the positives, the highs, the joys of life.
Fair. And I think just because you brought that up, I'm going to, it was a question that I was reserving for the end of this conversation, but considering that you brought up this example where the use of medications could actually curb much needed change, so I was a psychologist before I went to medical school, and I haven't seen, I don't know of any models of work that would, and when I say models of work, I'm thinking in general terms, guides or guidelines, where we would think of antidepressants as resources, but matched to a rationale where we are really not preventing change. And that would be my question. Is there any model out there? Is there anyone who ever, I know, for example, there was a fair amount of production in psychoanalysis and prescribing, even Gabbard here in the United States published something, but I went through a lot of what he wrote, but I couldn't find to be honest, I couldn't find, considering how complex psychoanalysis is, a teachable model of that I could, sort of learn and then again teach on my end of things to say, okay, how can we use antidepressants? What circumstances? What major framework can we use to say it's useful here to help you go through something, but it's not going to be useful here because it's going to prevent you of, moving on in life and so forth, so on.
So my view is that there is not really much role for the use of antidepressants. And so I'd like to just emphasize that I think there is a role for the use of other drugs. But I think if we think about depression, it is a reaction to people's circumstances. It is time limited in itself. People do come out of it, and people are more likely to come out of it if they address the circumstances that are making them depressed. People have different sensitivities to depression. We're all different, and what's happened to you in your childhood is going to make you more or less susceptible, and maybe genes play a bit of a role as well. But nevertheless, depression is still by and large a reaction to someone's circumstances or life events, even if people are not aware of that. And often people aren't aware of why they're depressed at the time, and that's why that's part of the role of therapy, which I wouldn't say everyone needs or is right for everyone, but one of the benefits of therapy can be to identify why someone is depressed and then help them find the appropriate solutions for it. And other than the use of medication to temporarily to improve sleep, if someone's sleeping very badly, or to deal with really acute agitation, or acute feelings of panic or something like that. So other than short-term use of sedatives, I don't really see that medication has a useful role in the treatment of depression. As I say, I wouldn't say that for all other mental disorders. I think that there is a role for drug treatment in the treatment of psychosis, and probably a little bit more in the treatment of anxiety. But I think in depression, the key is people trying to identify why they're depressed and resolving those issues.
Makes sense. And I know that from your book, you made a comment on efforts to either change or expand the diagnosis of major depressive disorder to include more or to overlap more with anxiety, which is not surprising considering the huge overlap that the diagnostic criteria itself has, as reliable as it is. Do you mind developing a little bit on that.
So yeah, I mean, we used to refer to neurosis, didn't we? That it was just going out when I was sort of doing my training. But we used to have this concept of neurosis, which was really a catch-all for anxiety and depression, and maybe a word for people who were struggling with life in one way or another, but not acutely psychotic, not obviously psychotic. And I think that's, is a reasonable way to look at things, because, trying to, we have all these diagnostic labels: depression, anxiety, panic disorder, as if we are, identifying some underlying biological deficit, but really we're not. We're just describing patterns of behavior and what people say to us, or how people are describing their difficulties. And I think probably having a more sort of global concept is useful in a way for not misleading us into thinking that we are really identifying specific different diseases. On the other hand, there is also the worry that it just creates a bigger market for antidepressants, and that may well be some of the the push behind trying to expand the depression diagnosis. It certainly there was certainly a push in that direction when the drug companies wanted to market antipsychotics for the treatment of depression. So a push to expand depression at that point, or expand the indications of drug treatment of antipsychotics for the use in depression anyway.
Makes sense. Now, we see that, going through your work, and there's a lot of production going on at this point, pretty much pointing excesses of the psychiatric field, motivated or not by good intentions or by financial pressures or biases. But at a bare minimum, looking at all those things, if we look into for schizophrenia, the open dialogue clinic and approach, we have here Vermont group, we have Soteria House, then there's the group in Finland, and now just today I learned there's a similar project going on in New York. And if we take into account evidence from antidepressants and failed randomized controlled trials using active placebo, for example, and all the concerns we have for randomized controlled trials that involve discontinuation from an antidepressant that has withdrawal symptoms, switch to a placebo, and then patients feel miserable and they say, well, I'm not doing so well. And then that kind of confirms, the expectation, I would say, that antidepressants work. To a bare minimum, we would be practicing in a more conservative way. Bare minimum, we will be holding back a little bit the amount of drugs, the initiation of the drugs, the overall total doses of the drugs. Now, I don't know how legalized medicine is in the UK, but in the United States for the longest time was really like a shooting. Everybody was running everywhere with this thing. And now things seems to be calming down a little. But in general, and if you look historically, I guess my question is, do you see legal aspects preventing doctors from holding back, from being more conservative, from looking to guidelines in a more critical way, considering that one of the concepts that are taken into account during litigations is what is considered standard of care, which it's quite concerning because the standard of care has been a little bit out of whack, to say the least.
So we are probably slightly less litigious in the United Kingdom, but we have vast numbers of people taking antidepressants. So in 2017, 17% of the adult population in England were prescribed antidepressants, and it has been going up since then, so it may well be higher now. And 1 in 10 young people is currently taking antidepressants. So we've got huge numbers of people taking these drugs. The evidence base, at its best, the most the most positive view you can take of the evidence base says that antidepressants are a little bit better than an inert placebo. Now, in my view, there are artifacts of the methodology that probably account for that difference. So even that difference is probably not a genuine pharmacological difference. But even if you accept that, that small difference does not justify these millions of people that are taking antidepressants in the UK and worldwide. And we have definitely been far too cavalier about the use of these drugs. We have assumed that that they're doing some good and not going to be doing any significant harm, but it's becoming apparent that they are doing harm, that people become physically dependent on them, which shouldn't surprise us because, as I said earlier, they are drugs that change our normal brain chemistry. They change the normal state of the brain. And so, lo and behold, as we could have predicted, when people stop taking them, they get withdrawal symptoms because the brain has changed, has adapted to their presence. And sometimes those withdrawal symptoms can be really severe and prolonged and make life really difficult for people, be very debilitating, and can sometimes go on for years. And in addition to that, we know that antidepressants commonly cause sexual side effects while people are taking them, but there's increasing evidence now that for some people, those sexual side effects persist after they've stopped taking antidepressants. Now, both of these long-term complications are potentially really serious and we don't know, and long term, we don't know, they might go on forever. Hopefully not. And there is evidence with the withdrawal symptoms that they do subside eventually. So these are really significant harms that are occurring. And given the millions of people that are on antidepressants, even if they're not that common, and they are reasonably common, this is going to be a huge, we're storing up huge problems here, causing a lot of people damage and significant harm in their lives.
And there's a general understanding, as you mentioned, that what we call the presentation we call depression is fairly self-limited, and that was a more older literature used to bring that up and be kind of an understood thing. Even we could quote Eysenck, the British psychologist. He came up with a research saying, hey, 2 out of 3 psychiatric conditions resolve itself within like tops 2 years and like months 2 years. But then now, and which is unfortunately reinforced by empirical evidence, is that depression has become sort of a chronic condition when back in the day, everybody, and it's not like people started to look to this thing in the 70s, like we have Freud more than 100 years ago writing about it. And so do you think there's at least a remote possibility that the chronic use of antidepressants could be actually resulting in this persistence of, ongoing mood or low functionality in general?
I think there are two things happening. I think, first of all, we are labeling as depression chronic unhappiness and misery that previously wouldn't have got to a psychiatrist. So I think that's part of what's happening. But I do think we are probably making things worse. And I think we are likely to be doing that partly by affecting people's beliefs about themselves, by telling them that they have a psychiatric condition, which many people will interpret to mean there's something wrong with their brain. We are giving them a very negative message about the possibility for recovery and the possibility for them being able to change their situation. So I think that's hugely significant. I think basically we are creating some chronic patients, some people with really chronic difficulties, by giving them the wrong message about their problems. And then I think antidepressants may, and I only say may, because I think we just don't know enough about them in the long term, but I think they may in some cases make people apathetic, lethargic, demotivated. I wouldn't necessarily say that they give them depression or, give them a relapse of depression, but I think they probably do create some long-term alterations, behavioral alterations that overlap with depression.
Makes a lot of sense. Now, one thing that I do before I prepare the interviews for the podcast is I have a fair network of colleagues in the field, and what I do is I test ideas. I run those ideas by people very carefully just to see, what kind of points. And to be honest with you, I'm looking for resistance and ways to overcome it. One of the things that came up when I said, hey, maybe there's a better model of looking into medications. Maybe we're just inducing temporarily dysfunction in a desirable way. It's like as if I have a side effect that is desirable for a given amount of time. And one of the questions that came back to me was, well, I have seen catatonia being reversed by a dose that is not enough to make someone sleep for many hours, or the same for a manic episode that would fairly said maybe cease, and I would call a fair return to baseline seen with the use of maybe lithium, maybe Depakote, with maybe 1 day of treatment on occasion. Of course, one of the limitations of empirical evidence is we're not comparing that same person to that same person without the treatment. But do you have any thoughts in that regard? Any points?
Yes. So I think it's really important to remember that most psychiatric disorders improve of their own accord. So that's what, when we do placebo-controlled trials, a lot of people get better in the placebo group, and that is down to a number of things. It's partly people's expectations of the effect of the drug, but it's also partly just the natural history of the condition that they have. So if we're thinking of something like mania, people improve from mania. Most people do. I mean, chronic mania does exist, but it's pretty rare. And giving someone who has mania a sedative drug, any drug with sedative effects, which includes lithium, has very strong sedative effects if you don't poison people first. Sodium valproate, also a strong sedative, and any of the antipsychotics, they're all sedatives. All of these things will make someone with mania look better, because mania is hyperarousal. If you give someone sedatives, they will calm down, their arousal level will reduce. So that's what I think is happening with mania. With psychosis, I think the same sort of thing is happening. When someone's acutely psychotic, they're often aroused and distressed. But antipsychotics also have this emotional numbing effect, this slowing effect, which I think reduces the impact of psychotic symptoms, reduces the intensity of those symptoms. So that also helps someone improve. But we have to remember, but that's why it's really important to remember that people do naturally, most people will return to baseline. So when people say, oh, we gave someone these antipsychotics and it wasn't just that they were a bit numbed, they really got completely better. They were completely back to baseline. Well, that's probably because that's what would have happened anyway in the course of time. They would have got completely better in time. And it might take a few months. I mean, I think the other thing that's important is we expect everything to happen so quickly now. But if you look back at historical accounts of mania, for example, or psychosis or depression, people were unwell for months. But that didn't mean they'd be unwell forever. They were unwell for months and then they got better.
Yes, and they didn't have to dwell with diabetes, high cholesterol, obesity, cognitive impairment, and all kinds of things that would come with the chronic use of medications, which now is seen as a needed thing.
To say that short-term treatment for something like acute mania, I think, can be really helpful. People are a lot of people are obviously totally out of control when they're manic, and they need looking after, and some sedation is a sensible thing. But I think it's just important that we recognize what we're doing. We're not reversing this in some magic way. We're containing people, and we're using chemicals to help with that containment process. And that's okay, that's fine. But, if we look at it like that, we know that it's not a good idea to use those chemicals for any longer than we really need to.
Perfect. And the other thing is, again, I think, this either review of the evidence, or it's a review because evidence has been around for a long time, even for questioning the need for chronic use of medications. And also looking to the open dialogue model, if I understand correctly, they try to hold for 2 solid weeks the use of medications, except for whatever helps the patient sleep. And then and if they don't see a progress or any improvement within any trend towards improvement during the first 2 weeks, then they may consider medications. That would again make me think of, okay, being conservative would be a very first step, and watch the pattern before start inducing all kinds of, and of course safety trumps all things for the most part.
So when I was a junior trainee, so this is back in the early 1990s, it was standard practice in the UK, if someone was psychotic, that they would come into hospital and be kept without treatment for 2 weeks. That was normal practice. And that was because it was recognized, first of all, that you needed to get the diagnosis right. You needed to be certain that someone was really psychotic. Some of those people would just get better quite quickly on their own. And you needed to be cautious about starting drug treatment. So it was partly, you need to be clear about what's going on, clear about your diagnosis, if you want to talk in those terms. I don't like the use of the term, but that's one way of putting it. And you needed to be very cautious about starting someone on drug treatment that they might end up on for a long time. So you're absolutely right. I think we should go back to that that much more conservative model that gives people a chance to get better first without drug treatment, but recognizes that some people during that time are going to need some containment and some support.
Perfect. And it's unlikely, then continuing on this topic, it's unlikely that, because you see the paradigm that we are trained nowadays is that describes, for example, depression as an entity, generalized anxiety as an entity, bipolar as an entity, schizophrenia as an entity, as opposed to just be presentations, God knows coming from where or from what. I think it's much easier to address depression and anxiety regarding anxiety frequently as a trait, but also as a reaction to life events and stressors and things like that. But it's unlikely that the training in psychiatry, either for psychiatrists, MDs, DOs, or nurse practitioners, will start taking into account this more conservative evidence. Do you have any ideas of how these things can actually be sprinkled down to start changing the practices, and in hopes to minimize long-term side effects? I mean, we have an army of people in America now taking antipsychotics for, you name it, like the lack of specificity of the treatment, and probably financial push. We have people diagnosed with depression, OCD, generalized anxiety disorder, bipolar, schizophrenia, in addition to eating disorders. There's really nothing left that we could make a case, please don't give antipsychotic. Maybe Parkinson's disease associated hallucinations, and even for that we have I think is pimavanserin. So do you have any ideas of how this information, this caution, could be spread?
So I think there are so many things that need to happen and need to change. First of all, thinking about antidepressants in particular, I think we need a public information campaign to correct the misinformation that people have been fed for so long, to correct this idea that people have been given, that it's been proven that depression is due to a chemical imbalance. We need to inform people that that is not correct. You were misled. So that's one thing we need to do. We need to help clinicians to resist prescribing. whether that is making sure that, stopping interaction with pharmaceutical firms. I don't see why that shouldn't happen. I don't see why we let pharmaceutical firms, bribe clinicians, wine and dine them and that sort of thing. The situation has got better. It's certainly in the UK. It's much, the level of bribery going on is much lower than it was. And that's partly because there've been very good campaigns led by some major, medical leaders, such as the ex-editor of the British Medical Journal, led a big campaign about 15 years ago now, against pharmaceutical industry. So it has got better, but it's still there. And I think there's much more we could do to stop the pharmaceutical industry pressurizing and bribing and persuading doctors to prescribe. And litigation always helps as well. So maybe some court cases over antidepressant dependence. I don't know if people are going to be able to take those, but it seems to me that they might have a chance of succeeding and might make doctors more cautious about starting people on antidepressants. Doctors are much more cautious about using benzodiazepines nowadays, so there's no reason why they shouldn't extend that caution to antidepressants. And I think it's but I think we do need public information as well, so that doctors are not being pressurized to prescribe. As far as antipsychotics go, I mean, we just probably need more information to get to clinicians about all the well-established adverse effects of these drugs, don't we? Like you mentioned, they cause obesity and diabetes. They've shown to reduce brain shrinkage. I mean, no one should be started on these drugs who is not really desperately psychotic, in my opinion.
Perfect.
They just have so many harmful effects. I do think when people are really acutely psychotic, they can be useful, but you really don't want to start them and you don't want to continue them unless they're really necessary.
Perfect. And what do you think are limitations? Because, again, back to the concerns with litigations and in the concept of standard of practice, when patients and doctors altogether face adverse results, what I see, and I'm trying to bring a lawyer that is has a fair amount of experience in this topic to the podcast to discuss these things, hopefully in a sense as a way to authorize doctors to be able to make individualized decisions again, as we would hope was still the way, but is clearly not. But what do you think prevents this concepts, warnings, and even evidence that has been collected over the few decades, showing that, okay, medications are not as good as we thought. Medications may have some, even in the case of antipsychotics and the supersensitivity psychosis, and actually perpetuate. There's much more evidence there of perpetuating psychotic symptoms. What prevents that to make a dent or affect our main guidelines? Let's say Maudsley prescribing guideline, NICE guidelines. What do you think is between this set of information and a more overarching authorization to take those things into account so people don't get themselves in trouble?
That's a really good question. How do we change the mainstream point of view? How do we even nudge it or move it a little bit? I've thought about this a lot. I think it's partly that the mainstream psychiatry is really strongly wedded to this disease-centered model of drug treatment because it supports its professional status. It supports its claim to be a bona fide branch of the medical profession, supports the claims of medically qualified people as against non-medically qualified people in the realm of mental health. And I think if you highlight that our drugs don't target underlying abnormalities, that makes psychiatrists feel insecure. So they, I think, are trying to avoid that point of view. And I say that because of the reaction that we got to the serotonin paper that we published recently. You know, so many psychiatrists were so angry that we even suggested that antidepressants that it might be worth thinking about how they work in different ways from the idea that they are targeting an underlying serotonin imbalance. They did not want people to start thinking about these drugs in other ways. They did not want people to start thinking about them as drugs that are changing our normal brain chemistry, and clearly found that very threatening. And as I say, I think that's to do with issues of professional status. So I think changing the mainstream view is very difficult. It is very wedded to the idea that we have drugs that are treating the underlying problem, or at the very least treating the biology of the symptoms that people have, or the proposed biology, the hypothesized biology behind the symptoms that people have. And I think anything that suggests otherwise is perceived as threatening. And of course that idea also backs up the idea of long-term use of drugs. You think that, if you think the drugs are rectifying some underlying abnormality, you can justify long-term use. If you're talking about them as means of containment or subduing people, then long-term use looks more questionable. So I do think it goes back to the way that the profession is really wedded to this disease-centered model, which goes back to its medical identity and its insecurity about its medical identity. And whether we will be able to budge the profession on that, I don't know. I do think I don't think it needs to necessarily be professionally threatening, because, like I've said, I think there are legitimate uses for drug treatments for mental health problems. But I think, like you're saying, we do need to be more cautious and more selective, and actually more educated and sophisticated in our use of and intelligent in our use of drugs, rather than just throwing them around everywhere. We've got to understand the drugs that we prescribe a lot better, and that will enable us to work out when they are going to be beneficial and when not. Prioritize short-term treatment, raise questions about long-term treatment, try and reduce that, etc. So yeah, sorry, I'm not sure I've answered your question about how to shift the mainstream.
You actually, I think you answered as good as it can be answered, because it is a really difficult and is a concern I have, because when I get feedback from folks and say, oh my God, I didn't know those things, because we all have been trained under a given paradigm and nobody was really questioning anything. And which leads me to my probably last question. And the reason this podcast came about was because I moved from inpatient psychiatric care, where I had, when you're in inpatient psychiatric care, you have a fair grip on what is done, and you can clean up medication regimens in a safer way, and you can be more purist. Even if you're just following guidelines and working under the usual paradigm allows you to clean up things and just try to make a sense out of things, and you see acute presentations and things like that. And then I switched to outpatient care, and when I started to work with outpatient, I felt awfully overwhelmed, because every new assessment that I was inheriting or being transferred from another clinic was really like an experience where I couldn't make a sense of things in terms of the number of diagnoses, the number of medications, the antagonistic effects of medications, if you will. And I started, then I said, I work with Pedro in a mentoring institute that had pretty much the goal of just looking at things critically. And I said, okay, man, let's put together a podcast. And as I started to advance in the podcast and look into things and, look for people with critical view of things, I started to find a lot of things that I should have heard. And I honestly, I'm super grateful for my training. I think it was a very good training. All my colleagues are very conscious providers, and they're very conservative in general. And and when I present these ideas to them, they go like, "Oh, yeah, kind of makes sense." And they sort of were working with. I think we had enough medical philosophy and first do no harm hammered in our heads that we were already fairly more cautious than the average. And but the feeling that I'm having now, because I'm sort of opening my eyes to this world, is that there's a lot going on. And the feeling I have is there's a wave going on of critical view and critical thinking in psychiatry. But it could be my bias because I am just seeing the wave for the first time, and I'm sort of surfing on it. Is that impression correct? Do we have more people coming on board, more people questioning, more people reading, more people looking to this thing, or no? Because I know you have been fighting this battle for longer, and I wonder if it's a stagnant thing or if the movement, if it feels like a wave, because that's how it feels to me.
Yes, I'd probably agree that in the last few years there's been building momentum in critical psychiatry and critiques of the mental health world. Critical voices have been around for a long time. And in some ways, I would say that going back several decades to the 70s and 80s, there was maybe more critical thinking within the mainstream in the shape of social psychiatry. Certainly in the UK, there was quite a big social psychiatry movement, and there still is, to be fair, a fair amount of social psychiatry going on. But that was very much part of the mainstream going back a few decades, and then I think got edged out by biological psychiatry for a few years. And I think maybe what we're seeing now is a reaction to that, as people who, are saying this sort of very reductionist approach to human beings really doesn't make any sense and isn't getting us anywhere. And I just wanted to comment on what you said about how these issues came to you when you moved out of acute psychiatry, because I think that's really interesting too. When people are really acutely unwell and they're coming into hospital, they do need care and containment. And as I said earlier, sometimes, drug treatment can be a really legitimate and helpful part of that. The trouble is, we leave people on stuff and they leave hospital and then they're just on this stuff for years and years on end. And really what we should be doing is, I think in many more cases, not necessarily for everyone, but in many more cases, helping people to get off things as soon as the acute episode is over, so that their exposure to these drugs is minimized, and also so that they then have a chance to develop other ways to manage the problems that precipitated the crisis or whatever it is that led them to get into hospital.
Makes sense. It makes perfect sense. Well, Dr. Moncrieff, Joanna, again, I'm very conscious of your time. Thank you very much for accepting our invitation. It was very good to have you here. You ever have any ideas you want to share to our audience, please send me an email. Please keep in touch, and you'll always be welcome here.
I will do. It was a great pleasure. And I hope it's useful for the listeners as well, but I enjoyed it.
Thanks a lot. I'll see you soon. Bye-bye.
This podcast was offered by anypmi.org.